Good day, everyone. This is Chris with the Ancient Scholar. This video is going to be in response to a request. Somebody had sent me a private message asking me if I could perhaps do a video on pulmonary embolism. So I thought I would try to do a real quick video on pulmonary embolism. Clearly, there's a lot more to pulmonary embolism than I'll probably be able to cover in 10 minutes. But be that as it may, I'll try to go ahead and cover those. So the book that I'm going to reference is this book here. It's actually what I used when I was in respiratory school. This is Clinical Manifestations and Assessment of Respiratory Diseases. This is the 6th edition. Okay, this is Terry Desjardins, George G. Burton. I believe Mosby is the publisher. Mosby Elsevier. It's a very good book. I highly recommend it. It's very easy to follow. Some great pictures if you're a visual learner. Just a overall really good introductory cardiorespiratory pathophysiology book. Really enjoy this book. So that's actually what I'll be referencing today. Okay, so what is a pulmonary embolism? Well, to understand what pulmonary embolism is, let's understand first of all what a thrombus is. Now, thrombus is obviously thrombin, and thrombinogen, and then obviously fibrinogen and fibrin clot. You can have this thrombus. Basically, it's a blood clot. Forms in a vein more often than not. These clots can form in veins for a variety of factors that I may or may not be able to get into. When that clot happens to become dislodged and travel through the venous system, we call that an embolus. Okay, there are all kinds of different types of emboluses. You can have something called a DVT, or a deep vein or venous thrombosis. Generally, these develop in the veins deep within our lower extremities, where I have what's known as stasis, where I don't have a whole lot of movement. Venous, obviously, we're talking about pretty low pressures. The driving pressure, the gradient that drives the flow is generally low. I'm going to have slower flows, so I can have stasis occur, and certainly in patients that are immobile, they sit for long periods of time. Long flights, for example, patients that have had surgeries and they're immobile and things like that. Can set people up for embolisms. So the major pathological changes that we see associated with a pulmonary embolism, so thrombus breaks free, it travels through the venous system, goes through the right atrium, right ventricle, and ultimately into the pulmonary artery and into the lungs, and can include an area of the lungs. Generally what we see blockage of the pulmonary vascular system. It can be large, it can be small. We see ultimately pulmonary infarction and death of the pulmonary tissue where that blockage occurred. We eventually have alveolar atelectasis. Consolidation occurs, and I'll also get bronchial smooth muscle constriction or bronchospasm. And we don't often associate all these findings with pulmonary embolism. But if the pulmonary embolism doesn't kill you outright, if it's not particularly large and you're able to survive, and you go through these other stages, these atelectasis, consolidation, and so on, these things will actually occur. Perhaps not acutely, but as it progresses, they will occur. So the big factors that can lead up to pulmonary embolism, well, there are 3 primary factors that we look at, and then lots of secondary factors. But these fall into something known as Virchow's triad. Really, there are 3 major things. The first thing is venous stasis. Anything that results in stasis or inhibits the venous flow, sitting for long periods of time, surgery, so on and so forth. That's 1. 2 is a hypercoagulable state. That means that I want to clot. My blood, for a variety of reasons, wants to clot. We see this in pregnant patients, for example. Patients that are prone to developing DIC, or disseminated intravascular coagulopathy, also very prone or hypercoagulable. And 3, injury to endothelial cells. That is, injury to the lining of the blood vessels, because that can of course, activate what's known as the intrinsic clotting cascade and make us want to clot. We can see this in shearing injuries and so on and so forth, a whole bunch of stuff. We see like venous stasis inactivity, varicose veins, thrombophlebitis, surgical procedures. If I've had long bone surgeries, obstetric gynecology, large joint surgeries as well. And, of course, when I'm talking about long bones, I can actually have a fat from the marrow released into the bloodstream, and those little globules of fat can become emboli as well. We can obviously see this with long bone trauma, hypercoagulation disorders, oral contraception, especially in women that get into the 40 and older, older women that are taking oral contraception, people that have polycythemia, certain cancers like multiple myeloma, severe obesity. Somebody has, say, atrial fibrillation, where there isn't a hypokinesis of the atria. I have I have a stasis occurring there as well. So lots of different things can lead us up to this. So the signs and symptoms, the big signs and symptoms of pulmonary embolism: sudden onset shortness of breath, tachycardia, anxiety, cyanosis with severe hypoxemia leading to hypoxia, cough. Sometimes I can get blood streak sputum, may or may not get some wheezing, chest pain that resembles a heart attack and the old Levine sign. So really some non-specific findings. So really we need to do a good history on patients having chest pain, dyspnea, because pulmonary embolism can be very difficult to differentiate from other problems, because it can cause bronchospasm and all these other findings. But really it's the history. Anything that revolves around this Virchow's triad, if that patient has any of these comorbidities or these pre-existing factors, we need to at least consider the presence of pulmonary embolism. So how do we diagnose a pulmonary embolism? Well, there's some non-specific tests like a D-dimer. A D-dimer is called a fibrinogen test. If it's elevated, it says that there's some sort of hypercoagulopathy going on, hypercoagulation going on. But lots of things can elevate our D-dimer, so we can't diagnose PE based on that. We can do a Doppler ultrasound and look at the veins, especially of the lower extremities. We can do MRI, but that takes a while. It's prohibitive. We can do something called a VQ scan or ventilation perfusion scan. Can provide us some good amount of information. Really, the main modality that we find is a CT scan. We can do a spiral CT of the chest, and we can fairly easily, fairly quickly, and reliably identify even fairly small pulmonary emboli or embolism in the lungs. So how do we treat somebody with a pulmonary embolism? Well, supportive care, ABCs, oxygen, anticoagulants will probably be given to prevent clots, things like heparin. And then we may consider fibrinolytic agents such as urokinase, redoplase, and so on. Large PEs. We can also do surgical procedures. In some cases, after the patient's stabilized, we can put in what's something known as a Greenfield filter, which is a filter that goes into the inferior vena cava and can kind of collect these clots before they get into the lungs. Pneumatic compression stockings to prevent pulmonary embolisms from occurring. Like I said, we may even look at invasive surgical procedures like pulmonary embolectomy, where we actually go and take the emboli out. Some of the treatments we may look at doing, obviously oxygen therapy, monitoring, maybe even aerosolized bronchodilators. Again, in the later stages, as I develop vascular changes, atelectasis, bronchospasm, I can get, wheezing and bronchospasm as a result of a pulmonary embolism. So we may end up giving bronchodilators later on. In some cases, we may, have to intubate and provide high FiO2s and PEEP to increase oxygen levels. And in very large embolism, our patients can present with sudden cardiac death, and clearly that doesn't have a particularly good outcome. So that is just a basic introduction of pulmonary embolism. I know it was very quick, but hopefully you guys got something out of that. And as always, thanks for hanging in there.